الفكرة جت لما نشرنا ال position statement from the Egyptian Society of Cardiology on how to manage cardiac patients during COVID-19 pandemic among patients. وفي الأول كان يعني تخطيطنا إن احنا نقولها في محاضرة واحدة، لكن الحقيقة لقينا إن this deserves more than one webinar. وزي ما حضراتكم شايفين ان احنا هنعمل a series of 8 webinars على مدار 3 ويك اندز، وقدرنا بحمد الله ان احنا يعني نستقطب مجموعه كبيره جدا من اخواننا وزملائنا المصريين اللي عايشين في الخارج. معظمهم شباب، لكن الحقيقه كلهم حاجه تشرف، وناشرين بيبرز في هذا الموضوع، بحيث ان احنا كلنا هنتعلم منهم ومن الاكسبيرينس بتاعتهم on how did they manage cardiac patients during the COVID-19 pandemic. معانا زملاء بيتكلموا عن الدايجنوزز، في ناس هتتكلم عن المانجمنت سواء كان heart failure او acute coronary syndrome patients او the EPS lab على مدار ومعانا طبعا الحقيقه هيبقى في اخر ويبينار استاذ دكتور محمد هيكلمنا من ناحيه التشست. الدكتور عوض تاج الدين استاذ الصدر في عين شمس هيتكلم عن المانجمنت from the chest point of view, chest specialist point of view، وهو حاليا مستشار رئيس in this pandemic. ومعانا كمان ستيفن باخ هو البريزيدنت elect of the European Society of Cardiology، هيتكلم عن اخر بيبر جايد لاينز الحقيقه اصدرتها اليوروبيان Society of Cardiology in this regard. دي المواعيد اللي انا حابب ان حضراتكم كلكم اكيد شفتوها ونزلناها على الاي هارت بورتال او على صفحه الجمعيه على الفيسبوك كمان. I think ان احنا كلنا لازم نبقى موجودين مع بعض في الثمانية ويبينارز. This is to start with the first webinar اللي هنقدمه النهارده. زي ما حضراتكم شايفين ده السيريس of events او الثلاثه lectures اللي هيتقالوا. The first one I will speak about the position statement review article, and then Dr. Hani Mahmoud will talk about echocardiography, the role of echocardiography in the COVID-19 patients, and they actually published a paper about this subject, so he's a real expert in this regard. وأخيراً we'll have a short talk about Nebivolol in COVID-19 pandemic. حابب الأول بس إن أنا أرحب بالزميل العزيز والأخ العزيز دكتور هاني محمود. الحقيقة هاني حاجة تشرف المصريين كلهم. هو دلوقتي cardiology cardiac imaging specialist in Queen Elizabeth Hospital, University Hospitals Birmingham in UK. ولسه حالا سألوا عن الجو هناك في برمنغهام، فقال لي الحمد لله ان الجو بقى جميل ومشمس جدا، والكوفيد هناك بتقل. عقبالنا يا رب ان شاء الله ان الكوفيد عندنا كمان تبقى declining، لان احنا الحقيقه دلوقتي I think ان احنا عايشين في البيك of this curve. هو اخذ الام دي الدكتوراه من جامعه الازهر يونيفرسيتي، معاه بورد سيرتيفيكيشن from the National Board of Echocardiography من امريكا from the USA. ودي حاجه طبعا محترمه جدا وحاجه الحقيقه نفخر بيها. He's actually a fellow of the American Society of Echocardiography. اشتغل فتره في مركز اسوان الدكتور مجدي يعقوب، وهو الحقيقه بيفتخر بهذه الفتره اللي قضاها، واحنا كمان بنفتخر بالدكتور مجدي يعقوب وكل اللي كانوا بيشتغلوا معاه. وعنده مجموعه من الببليكيشنز and he's a reviewer, an eminent reviewer in many of the societies and the journals. واهم حاجه كمان ان هو was awarded as the best young investigator by the Egyptian Society of Cardiology. انا بفخر بالفتره دي اللي انا كنت فيها رئيس، والحقيقه هو فعلا مثال للشباب المصري الجميل المثابر. نتمنى له التوفيق وشرفتنا النهارده في هذا الويبينار. كنت كتير لكن حاطط للأستاذة الدكتورة الفاضلة أستاذة الدكتورة هالة محفوظ، وهي أستاذ القلب في جامعة المنوفية. And actually she is the editor-in-chief of the Egyptian Heart Journal. And she's got a lot of experience in echocardiography. That's why she was actually invited and she accepted, alhamdulillah, to be one of the panelists and the moderator of this session and in this webinar. تفضلي دكتورة هالة، الكلمة ليك.
Hello everyone, welcome to the today's session. Thank you very much, Professor Dr. Sameh for this kind introduction. In fact, I believe this is one of important webinar introduced by the Society of Cardiology. Let me say just a word about what we are doing with these words. In fact, this is the most difficult health crisis we ever see. We tried to make a guide to all clinicians, the cardiologists, the healthcare providers about the patient to improve the quality of the patient care. But not only that, in fact, we are looking for the safety of the personnel, how they taking care of themselves, of the hospital, of the in Egypt. We all know that we have a little bit limited resources, and that's why there is always a gap between the best quality and the safety, and then the guidelines taken by the whole developed countries in these days. Now we will go to the science. I am very pleased and honored to introduce Professor Dr. Sameh Shaheen. As he just said, he will introduce very important statement for the position statement of the Egyptian Society of Cardiology. It's titled The Rapid Guide to the Management of Cardiac Patient During the COVID-19 Pandemic in Egypt. Professor Dr. Sameh Shaheen.
Thank you very much, Professor Hala. And actually, as exactly you put it in right phrases and right words, that the core of this position statement is to guide our colleague cardiologists to how to manage cardiac patients during this pandemic, whether they are carrying the virus itself and are COVID-19 positive or not. And in fact, this is a guide on how to deliver a good quality of care to our patients, our cardiac patients. And at the same time, as Professor Hala mentioned, to protect the medical staff and to protect the patients from getting the infection, and to make sure that the infection is limited and is spreading all over to the facility or to other patients. Actually, a cardiologist might face one of these three scenarios in dealing with cardiac patients. Either he will see a cardiac patient that's known to him coming to his clinic or to his hospital with symptoms that might be suspicious of COVID-19. We all know the overlap between cardiac symptoms and chest symptoms, like shortness of breath or even cough. So the first question is whether this known cardiac patient with, say, for example, heart failure or patients with valvular heart disease or ischemic heart disease is this patient having just cardiac problems, or is he suffering from the complications of COVID-19 infection? The second scenario is having an undiagnosed patient that you might see him for the first time, and again coming with this symptoms that can be either cardiac symptoms or chest symptoms like shortness of breath or dyspnea or dry cough or cough with expectoration. These symptoms might be due to cardiac problems, I don't know, or it might be due to COVID-19. So we have to be very suspicious in such scenarios, and in order not to have the dissemination of infection, which is supposed to be present in any of these patients. So we'll tell you how to protect yourself, your medical staff, and other patients in the medical facility from this suspected infection. The third scenario is to be called to see a patient already diagnosed as having COVID-19 positive case, and this patient unfortunately is suffering from any cardiac complication, as we will mention. So again, you might be called to see a patient who is non-cardiac but with COVID-19 positive, but already having some sort of cardiac complications, and we'll see what type of complications might be seen in this patient. This is or these are the type of complications that you might encounter in these three scenarios. You might have an exacerbation of previous cardiac problem, a patient who was already having a heart failure, but now he's having a deterioration of his cardiac condition due to his chest problem, or due to the fever or the tachycardia or the chest infection, or having acute de novo heart failure. This is again another type of complications, or having acute myocarditis, and this is now has been reported to be relatively common. In many papers, we are reporting an incidence of from 20 to 25% of either clinical myocarditis or elevation of the cardiac enzymes. And again, your patient might be presenting with a picture of acute coronary syndrome, whether ST elevation or non-ST elevation. Acute coronary syndrome patients, we know the thrombotic tendency of this pandemic. We know that there might be some coagulopathy, plaque rupture. All of these have been reported, and we are seeing it in our hospitals. Professor Khaled Shokry told me that he has seen some patients presenting with acute stent thrombosis, and nothing to explain this except being positive for COVID-19. A lot of patients presenting with Dvt and pulmonary embolism, and this again might be a cause of sudden cardiac death in these patients, and that's why the D-dimer is becoming very important to assess the problem and to give anticoagulants either or as a treatment for Dvt and pulmonary embolism. Patients might suffer from arrhythmias. I've seen many patients with atrial fibrillation, a new onset atrial fibrillation in this regard. And you know the dilemma that we are facing with the use of hydroxychloroquine and the incidence of prolonged QT and torsade de pointe that might be induced. We are not sure yet of if this is a serious problem or not, especially if it is combined with azithromycin. Many patients might present with Takotsubo-like syndrome with apical akinesia and normal coronaries with no atherosclerotic lesions in the coronary arteries. And definitely we are facing problems again, as we have mentioned, with the side effects of the COVID-19 treatment. What type of investigations we are asking for these patients? Definitely we have this lab investigations, and they aid in the diagnosis of such cases, especially from our cardiological point of view. D-dimer is very important, very essential. Cardiac enzymes, again, are very essential. Now the CT scan for the chest is playing an important role for diagnosing the case of pneumonia, even if the patient is having a PCR which is negative. CT chest now is more sensitive nowadays, and this is the typical criteria that you might face in this. And we will have our colleague Mohammed Marwan from Germany. He will talk about the role of CT, whether cardiac or chest, in COVID-19 patients. I think it will be an important session in the following webinars. We should do ECG, and we should follow the patients for arrhythmias, ST changes, ischemic changes, or a QT interval follow-up. This is very important, and definitely echo. And the expert today, Dr. Hani, will give us a presentation about the role of echo in COVID-19 patients. And this is, of course, you have to ask for sometimes definite diagnosis for acute aortic syndrome or acute pulmonary syndrome. Remember always that the CT scan can help in these three diagnoses together. So this is a very actual, helpful tool in nowadays, and actually we are using it a lot nowadays. Bedside echocardiography, we'll hear again from Hani whether you should do a full echo or a focus echo. This is administrative orders that we should be doing it now. I think Egypt and the Ministry of Health is doing a very good job now in defining COVID-19 designated hospitals for isolation of positive patients, and non-COVID-19 designated hospitals, other hospitals which are receiving other patients who are not COVID-19. And actually, we have to remember these patients, and we have not to neglect patients who are not suffering from COVID-19. And we all know the reports from all over the world that the presentations of STEMI patients has been declined to up to 50% in some centers. And the big question was, where are the patients? The STEMI patients, where have they gone? They are, of course, afraid to go to these patients, to hospitals nowadays. Inside the hospital, you have to do a good arrangement with the infection control unit. This is their time. They have to put you the plan for infection control in order to prevent the spread of infection. This is very important, and every unit in the hospital should abide to this. The outpatients or the inpatients or the cath lab, and of course we have to defer most of the elective procedures because this is the time to take care of other patients. Dr. Haitham Suleiman Gharib will be with us tomorrow, and he will talk about actually a very important lecture about how to protect staff and the use of PPE or the personal protection equipment. This is very important item. I think we as a cardiologist should be very much aware, very much trained in this regard, because we have seen, unfortunately, a very high incidence of medical staff infection in this regard. So again, we are stressing on the importance of keeping everybody safe in this regard. The proper way of doing the donning and doffing of the PPE is very important. Hani Gharib tomorrow talk about this. Training is very important. I think this is very important, and I will leave this. The level of PPE differ according to which place in hospital you are dealing with. And I think, again, we have to take care of the outpatient management. Dr. Hani Sabur, an eminent cardiologist, from the USA and actually now in the Emirates, the United Arab Emirates, will talk about the management of heart failure patients with the use of telemedicine. Very interesting experience in the United Arab Emirates and in the USA in order to avoid overwhelming of the outpatient clinics with heart failure patients. He will show us how to follow your patient, how to let him give you the latest information about his body weight, about the urine output, about even to put the phone in front of his neck veins to see if it is elevated or not, to see his whether he is having lower limb edema or not. Everything in this regard, we will be talking about how to do the non-invasive should be done under which type of protection, because again, this is very important. This is for the outpatient. What about the ER? Again, our recommendations as a society, the Egyptian Society of Cardiology, is telling our colleagues that the first question, if you are serving now in the ER of any hospital, is to ask yourself one question. The first question is very important: whether the patient is fit or needs admission or not. If the patient is having mild symptoms like fever less than 38 or just cough or sore throat, then there is no need for hospital admission and the patient is fit for home isolation and home treatment. This is very important in order, again, to take the load off the hospitals in this difficult times. On the other hand, if the patient is having moderate to severe symptoms like severe cough or fever above 38, then this patient is supposed to be in need for hospital admission, and we will do all the investigations that I have mentioned before. Which place in the hospital to admit the patient? Again, this is very important. If the patient is known to be positive with a positive PCR and positive COVID-19 patient, then these patients should be transferred to the designated isolation hospital. This is very important. These are the specialized hospitals that should take these patients, and I mark it in red. If the patient is not diagnosed, but we cannot rule out the possibility of having an infection, so he can be isolated in the non-designated hospital. In any hospital which is not an isolation hospital, there should be a place to isolate such patients in order, again, not to disseminate infection in these places. And if the patient is negative for the first PCR, then again, you have to be suspicious until you receive the second negative PCR. If the patient is having two negative PCR, then you can transfer the patient to the green area of your hospital, the regular wards and the regular CCU. Again, we have been stressing on the importance of the cath lab management in our paper. You have to, again, take the utmost precautions in order not to spread infection, starting from the corridors the patient are moving in. The staff dealing with the patients should be putting surgical masks. You should check the patient for temperature and for symptoms of possible COVID-19. The limited number of staff should be in contact with the patient. Everything should be really prepared as if the patient is having a COVID-19. There is no way to be less cautious in such patients, and unfortunately we have seen many medical staff, our close colleagues who have been doing cardiac catheterization and got the infection, and sometimes the prognosis is not very good. So please take care in this regard. This is the topic of Professor Hani Ateba. Professor Hani Ateba is an eminent Egyptian cardiologist who will give us a resume about his experience in Scotland. He is the president of the Scottish Society of Cardiology nowadays, and we are very proud of this. And he will tell us about his experience in dealing with STEMI patients in the UK. And I think, again, in the Egyptian Society of Cardiology, we are giving two possibilities or two scenarios. If the patient is not overwhelmed with COVID-19 positive patients, which I guess is not the case nowadays because now we are in the peak. If there is no overwhelming number of cases of COVID-19, then you should continue on doing primary PCI to most of your STEMI patients. This is the recommendations of the SKY. This is the recommendations of the European Society of Cardiology, again, because actually we know that giving thrombolytic therapy in this regard will not be successful. We know this beforehand, and even the patient will stay a longer time in the hospital, so he may be getting the infection. So still the primary PCI is the best option in this regard. But again, take care that this might be COVID-19 patients, and they might be presenting with ST elevation. That's why you have to be very cautious, and that's why we are not giving thrombolytic therapy in most of the instances, because maybe this is just a camouflage, if you wish to say that this is a COVID-19 patient. Anyhow, once you finish with the emergency, with the primary PCI, you have to do all the tests needed to exclude the possibility of being COVID-19. If it is COVID-19, then you should refer the patient immediately to an isolation hospital or a designated hospital in red. Again, if you are not sure, then you can isolate the patient in your hospital in special wards. And if the patient is having one negative PCR, then you should wait for the second negative PCR, then the patient can be transferred to the green zone. If the hospital is overwhelmed with COVID-19 patients and there is no time to do primary PCI and the staff is very much involved in COVID-19, then you can do like China. China has offered all the STEMI patients thrombolytic therapy. There was no emergency primary PCI in China during the pandemic. This has been their recommendation to start thrombolytic therapy for the majority of patients, except if the patient is having any contraindication to thrombolytic therapy or is presenting beyond the 12 hours, which is the window for thrombolytic therapy, or the patient is having rescue PCI after failure of thrombolytic therapy. These are the only indications for doing primary PCI in patients presenting with STEMI in this pandemic. For non-STEMI, I think it's more clear. You should concentrate with the high-risk patients to do early coronary angio only for high patients. All other patients should be managed conservatively. And I think, again, we should do all our efforts to diagnose whether the patient is having COVID-19 or not. This is very important. And we will have, again, a very important lecture from our colleagues in the EPS, in the electrophysiology studies, who will tell us about how to manage patients with pacemakers by telemedicine, how to do cardiac cath ablation procedures in this pandemic, what are the emergency situations that we should use. I think this deserves a whole webinar, and we have eminent speakers who will talk about their experience in this regard. I should finish, my dear colleagues, with these conclusions, that the challenge during the pandemic is in providing the best quality of care for our cardiac patients despite limited resources. We know that all resources now are going to COVID-19 patients, and truly they are in need for all these resources. But unfortunately, this will be on the expense of neglecting cardiac patients. So we have to remember that we should give the best quality of care to our cardiac patients, and at the same time keep our medical staff as safe as possible. This is very important. This is very important. We have seen a lot of medical staff that has been suffering from infection, and so we have to take care in this regard. All medical staff should undergo rigorous training on infection control and the use of high-quality personal protection equipments. Cardiologists should promote telemedicine in the outpatient setting, and believe me, this is not high technology, just video calls on your telephone, and you can follow up your patients without having to receive them in your clinic or in hospitals. Considering, of course, deferring elective procedures, and you will be amazed that many elective procedures that we did in the past was not needed by many of our patients. They are doing very well with medical treatment. So at least during the pandemic, we can defer many of the elective procedures, and we can depend on conservative approach for dealing with acute coronary syndrome. I thank you very much for this, for giving me the chance to give you this overview on this very important, I believe, a very important paper. And back to you, Professor Hala and Professor Khaled.
Thanks, Dr. Sameh, for this elegant presentation, and as well, it is a nice talk, and give a review on rapid review on the regulations we need to protect ourselves in this pandemic. I think there is a question from one of the medical staff, one doctor. If you, he did an echocardiograph. Yes, Dr. Dr. Hala.
Thank you very much. I just wanted to encourage all the participants to put their questions or queries about this topic. If want that, I am love to hear from the participants about any questions about the to cardiac patients in COVID-19. Dr. Khaled.
Only one question from one of doctors. He said that he did an echocardiography for a patient, and he was wearing a double face masks, and the patient also had a face mask, but he get an infection with the COVID. The patient was COVID, and he get the infection from the patient. What do you think? He wanted to know why he gets this infection despite these precautions.
Actually, Professor Khaled, I think that the recommendations for doing echocardiography is not only wearing a mask or putting a surgical mask. You
Yes.
should wear the whole equipments, the personal protective equipments, the overall, the covering of your head, the goggles, even the goggles, because you know that getting that close to the patient is not at all safe. A surgical mask is not enough. It's enough for the patient, but it's not enough for the doctor. The doctor should wear the gloves, should put the head cover, should put the goggles, should put the mask. And I think we'll hear again from Professor Hani how he's doing echocardiography in patients, even transthoracic echo. I'm not talking about transesophageal. Transesophageal is another story. It's far more hazardous. But even for transthoracic echo, you are very close to the patient. And even I think that, again, between the patients, you should be a very far distance in order not to be in close contact with the patient.
Yes, because we have to know that the source of infection is not only through respiration, but also through touching. I think the doctor asked this question. He thought that the infection can be transmitted only through the breath of the patient. but this is not true. He can get infection through touching any part of the body of the patient. So he must cover all his body, as you said, Dr. Sameh. Dr. Hala, you can review the other questions.
Dr. Sameh? Yes, there is another question for Sameh. One of the participants asked, Professor, if the patient is known to have DVT and getting anticoagulant, could we continue or to stop the anticoagulants if he known to have COVID-19 infection?
No, he should continue, of course, because even we are feeling that now the coagulopathy mandates giving prophylactic anticoagulants for all patients. Some papers say not all patients. We do first the D-dimer. If the D-dimer is normal, there is no need to give anticoagulants because we know the risk of anticoagulants that the patient might suffer from bleeding. So this is not, again, without price to pay. But if the D-dimer is starting to rise, then we should start with prophylactic anticoagulants, whether in the form of low molecular weight heparin or even oral anticoagulation like the NUX. So for sure, if the patient is already having a DVT and already on oral anticoagulant, by all means, I think he should continue on this and not to stop.
Dr. Sameh, I have a question. I asked some patients, some doctor who deal with this type of patients about there is. Do you think there is a rule for thrombolytic therapy in pulmonary complications in patients with COVID-19? Some doctors reported that critical patients with COVID-19 who are suffering from pulmonary embolism may be improving by streptokinase, and some doctors from abroad. I listened to lecture a few days before. When D-dimer increased about over a certain limit, I think 250 or something like that, he gave thrombolytic therapy. Do you think there is a rule for thrombolytic therapy in such cases?
From the experience of many of my colleagues, I think that the same rules that apply for non-COVID-19 patients apply during this pandemic. I mean, the thrombolytic therapy should be limited only to patients with hemodynamic instability. This is the role of thrombolytic therapy. If the patient is having hemodynamics instability and we are facing a large pulmonary embolism, a massive pulmonary embolism with hemodynamic instability, then for sure thrombolytic therapy will be of great benefit. But if not, if the patient is stable, if by CT there is no massive pulmonary embolism, so I think that the usual anticoagulants is enough in such case. So the same rules apply.
Okay, thanks, Dr. Sameh, and I think we have to move to Dr. Hani. Dr. Hala, you can introduce Dr. Hani.
Hani, Dr. Hani is our guest for the time being. He is the ICAVI Education Health Committee member cardiology. He's one of the eminent cardiologists, especially in the field of three-dimensional echo and advanced technology in echo. He has a very elegant a recent publication in the Echocardiometry Journal about the echocardiographic features in COVID-19 patients. And I am very pleased to introduce Dr. Hani, and he will talk about echocardiography in 19. Dr. Hani.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, dear professors. Thank you, Dr. Hala, for the introduction. And I have to thank Professor Dr. Sameh Shaheen and Dr. Khaled Shokry for giving me this chance of being here today. And my talk will be about the echocardiography in COVID-19 patients. So I have nothing to disclose as regard to this talk. I have other things to disclose in relation to advanced echo, but for the simple echo in COVID patients, I have nothing to disclose. So I don't have really to address or to repeat what have been said thoroughly by Professor Shaheen about the impact that COVID-19 has caused about the cardiology world. But as has been said, patients with COVID-19 can have either pre-existing cardiac disease, and some of them will develop, and this is what we are looking for, acute cardiac injury, biventricular dysfunction or univentricular dysfunction, and some patients will develop drug-related myocardial damage. Early reports from many papers has shown that there is worse prognosis for patients with cardiac disease, and these are the patients that will have prolonged stay in the hospital, and those are the patients that may need mechanical ventilation. Consequently, as those cardiac patients are getting sick and many of them will develop cardiac problems, that will definitely reflect on the echocardiography service and the demand on echocardiography, and this will eventually expose the echo personnel for COVID-19. Registries from all over the world, like Wuhan or New York and Birmingham in our city, because our hospital is almost the biggest university hospital in the UK and the busiest in terms of COVID-19 patients management and treatment. So from these registries, we can notice that patients with cardiac or cardiovascular risk factors are a larger proportion of those patients. That's why all the societies, like the British Society of Echocardiography, the European Association of Cardiovascular Imaging, as well as the American Society of Echo, all of them produced papers, position papers like the one elegantly done by Professor Shaheen and his colleagues to address how to approach these patients, not only what are the findings in those patients and what to look for, but more importantly, how to approach them safely, because we need to protect our staff as a priority. Regarding the indications of echocardiography in COVID-19 patients, I have to start with saying that COVID-19 does not equal echocardiography. So having the virus doesn't mean that you need a transthoracic or transesophageal echocardiogram. This shouldn't be done routinely in all patients with COVID-19, but it needs to be done if the echo will have an immediate impact on the patient management, as we will see later. Many indications to do transthoracic or transesophageal echo in those patients, such as acute or subacute onset of dyspnea, which is still negotiable because pneumonia will present with dyspnea, but again, this is one of the common symptoms between both scenarios. Edema, cardiac murmurs, whether new or worsening cardiac murmur for fear of infective endocarditis, patients with elevated cardiac biomarkers. In the ICU, it is very commonly requested to assess the patients in terms of the need for mechanical or circulatory support, and to assess the filling status in order to check whether the patient needs fluids or not. And patients generally with hemodynamic instability with the suspicion of right or left ventricular dysfunction, to assess pulmonary hypertension status and suspicion of pulmonary embolism will need transthoracic echo at least to be done. On the other hand, some parameters like normal pro-BNP might be good enough to stop a request or to reject a request if the patient is coming with dyspnea and at the same time he has a normal pro-BNP. That is enough cause, at least for us in our institution, to reject the echo request that this patient doesn't need a transthoracic echocardiogram because he is having normal pro-BNP. So let's go for the British Society of Echo guidelines. they have produced a very simple and very elegant algorithm on how to approach these kind of patients. They started with checking the staff of the hospital. So assess your healthcare workers first. All the healthcare workers that have high risk and worse prognosis if they got infected with COVID should stay away from the service. So doctors or nurses or even admin staff who has like malignancy history or recent malignancy patients, any one of them that have that has low immunity or immunocompromised for any reason, drugs, disease, or any of that, it should be kept away from the service. In our institution, all of these staff categories were given 12 weeks paid sick leave, and they are working from home if they can. So if a radiologist or anybody who's working, who can work online, he does this from home. And the admin staff, many of them who are like pregnant or high risk for COVID-19, they are working from home if they can. Otherwise, they are on leave to protect them. Second point is to assess the patient and categorize the patient in categories. Check if the patient is confirmed COVID patient, that's category 1, confirmed, or category 2, if the patient is suspected. Category 3 is low-risk patients. And the definition of low-risk patient is the patient that has no symptoms, the patient was not in contact with a positive patient over the last 2 weeks, and or confirmed negative swab, okay? So confirmed negative swab, but confirmed negative without symptoms, because we have some patients negative swab with typical symptoms for COVID-19. This is not a safe patient. You have to deal with that as a suspicious or even as confirmed COVID patients. After categorizing the patient, and then you check your staff, the remaining of the staff, whether they are fit tested for the N95 mask or not. Doctors or nurses or echocardiographers who are like me, for example, having a beard, they do not fit the N95 mask. So they shouldn't be doing the echo, or if they will have to do the echo or transesophageal echo, they have to wear the hood like what they are providing me in the hospital. The hood is a closed circuit with filtered air in order to be able to get fresh air, clean air while doing your scan. And then you receive the echo request. What to do with the echo request? First of all, the echo request should be done by senior staff. So either consultant or a senior specialist, in order to make sure the request is really appropriate and not to overload the system. Second point is, okay, this is requested from a senior doctor. Second point is to look for, is it really demanding or not? As well, the echo findings changes the patient management or not? And after that, what are the views necessary to answer this specific question? So you have to prepare your mind to minimize your time with the patient. We have seen a question from one of our colleagues today here that he did the scan. The patient was wearing a mask and he was wearing a double mask, though he got the infection at the end. The problem is not only that, even wearing the full PPE will not prevent anything 100%. This is known. But the trick is to limit the exposure time as much as you can. So plan your strategy first, even with transthoracic echocardiography. If the question is about, for example, LV function, and you got good apical or parasternal views, there is no need to go for the suprasternal or subcostal views. Why bother and why to take time? Wear your full PPEs before going towards the patient. So don't wait till you get close to the patient and you start donning and taking and wearing your full PPEs. Do this before going close to the patient, and then go to the patient just ready to start the scan, and so on. Ideally, we should use a dedicated machine, a dedicated scanner for the COVID patients. In many institutions like ours, we kept a machine in the COVID area. So each COVID area has an echo machine dedicated for that. This machine shouldn't go somewhere else. And ideally, the machine should be the easy wipe ones. So we have the machine that has no buttons. All buttons are touch and the screen is touch. So it can be easily wiped down clean without the difficulty of wiping around the buttons and so on, if it is available. If you are using a portable machine, it is better to remove the machine itself from the cart, from the commercial cart that comes with it, and put it over a surgical trolley. Surgical trolley is very simple and has no has no much corners, so easily cleaned, and so on. Remove any unnecessary items like pens, cards, papers on the table, so just the machine and the trolley, and that's it. All that to minimize the chance of cross-infection. The study should be done ideally bedside, so the COVID patient shouldn't wrap around and go and walk inside the hospital or be transferred around the hospital. He should stay in his bed, in his room, and the echo person should go to him with the machine dedicated for the COVID patients. If you are doing transthoracic echo, as we said, aim to reduce the viral load exposure for the healthcare worker by asking the patient to wear a mask. The patient has to wear a mask like what our colleague did. You wear your full PPEs or according to the policy of the hospital. And a good thing to do is to avoid breath hold. Many times we ask the patient to breath hold, to freeze the image in order to see a good window. Don't do this. Do not do this in COVID-19 patients, because we know once you ask the patient to breath hold and once you ask him, okay, you can release now, then the patient exhales and that can spread the droplets more. So avoid breath hold while doing transthoracic echo. If there is a personnel that can do the echo in the same area of the patient, let him do the scan. So if there is a person who is in the same area in the dedicated COVID ward, do not bring somebody else from outside the COVID ward to do the scan. It should be the one around the patient. Do not use any unnecessary items like ECG electrodes for the machine if you don't need to do offline analysis and difficult stuff. Finish acquiring the images first and then calculate later on. So do not measure the Dopplers and volumes and everything besides the patient. That will increase your exposure time to the COVID. Finish what you need to acquire first beside the patient and then close the machine, take the machine away, clean everything, and then start quantification later on. All of these measures are to reduce your exposure time to the infection. TOE, transesophageal echo, that's another story like what Professor Shaheen said. By definition, TOE is an aerosol generating procedure. So you have to deal with any patient while doing TOE like a potential COVID-19 patient. And this is actually what we are doing in our institution, because it was difficult to swab every patient before doing a TOE, not practical. So we had to deal with them as our COVID positive patients. We are wearing full PPEs because it's very dangerous and aerosol generating procedure. The British Society of Echo recommendations are all routine TOE cases should be cancelled. If it is routine, should be cancelled. And if it is clinically relevant, you should ask the MD members, MD multidisciplinary team members, those who will deal with the patient after you produce a report. Say, if you are sending this patient to assess if the patient has severe mitral regurgitation or not. Okay, what if I see severe mitral regurgitation and needs surgery? Will you do the surgery now or not? If the surgery will not be done now, so no point of doing unnecessary TOE now, even if it is clinically indicated, once you will not do the surgery now, because that will expose me and the patient to high risk and complications. So it needs to be clinically relevant request, and it will have an immediate impact on the patient, not later on. In the perioperative TEE, you need to make sure that the airway is protected. Even in ventilated patients, the patient has to have the cuff, the endotracheal tube, the cuff should be fully inflated to avoid any leak around the cuff, because this is aerosol generating as well, and it has to be a closed circuit, especially in the ITU setting. Many times, while moving the patient from side to side while doing TE, sometimes disconnection can happen or leaks can happen, and that again, aerosol generating. So you have to be very careful and wear your full PPEs and deal with every patient as potentially COVID positive patient while doing transesophageal echo. This is an example of a full PPE if you can fit this. Otherwise, this is my picture wearing the hood that was provided by the hospital, giving you a filtered air enclosed circuit because I have a beard and failed the N95 mask test. The European Association of Cardiovascular Imaging was not too different. They produced a more or less similar recommendation. I will not go through this in details because it is more or less similar. They emphasize the need to do appropriate requests only, and especially if they are life-saving or they will impact the patient management immediately, and they recommended to postpone or even cancel all the non-elective or the non-urgent elective tests. They emphasized again that the study should be focused study just to answer the specific question, and again they stressed on the danger of transesophageal echo as it is aerosol generating procedure, and they produced an algorithm which is more or less similar to the British Society one. These tables are very helpful, so you can put this in your lab and then check them for guidance. These are the risks of the patient: low risk, moderate risk, severe risk, which is COVID positive, exactly like category 1 and 2 and 3 in the British Society of Echo. And these are the precautions regarding hand washing, which is obligatory in all categories of patients, surgical masks and gloves, preferable even low risk, and then obligatory once you go for the more severe cases, and the advanced mask for the confirmed patients. And for the protective equipments, for sure, if you are dealing with moderate or severe cases confirmed positive, you have to take more precautions as you go on. For transesophageal echo, they are more cautious, as we said. So everything you will find obligatory, full, in order to protect yourself, and even the assistant or the nurse who is within the TOE room should be fully protected as well. Positioning, this is quite important. I know in Egypt, most of the echocardiographers are using this position. The patient is on his or her left lateral position, and the operator will be right-handed, so the patient will be facing on the other side, and the doctor will be on the back of the patient, and the machine will be on the other side as well. So that's the best position to use during the COVID pandemic, especially when you ask the patient to wear a mask as well, and you protect yourself as well, because that will decrease the contamination produced by the patient for the machine and for the person as well. And in some countries, like USA, I've worked in Birmingham in USA as well, they were using this approach. It is quite comfortable for the doctor, no lower back pain that we are facing, and the patient is comfortable, no need to hug the patient by your right hand, but it is not suitable in the COVID pandemic, because you are face to face with the patient. If the patient coughed, if the patient breathed deeply, you will get exposed extremely to the COVID if the patient is COVID positive. For the equipment, any non-necessary items on the machine should be moved. Like if you are going to do a COVID patient basic study, you do not need a 3D probe, you do not need the BIDOF, which is single Doppler one. Anything that you will not use for the patient, just take it away, don't take it to the patient side. If you don't need ECG for quantification or for strain analysis, which is unlikely in the COVID situation, take them out, don't take them with you. In high volume centers, like I said, we dedicate a separate scanner for the COVID patients. And for the TE probe, some hospitals will use protective coats, so you don't need to sterilize them or sterilize them quickly, provided they will not affect the image quality. And for sterilization of the TE probe, this is the regular sterilization. It doesn't need any further steps apart from the regular sterilization of the probe. For the sterilization of the equipment, moderately warm water and mild detergent are always enough, even for the probe. No alcohol disinfectant should be put on the membrane of or the face of the crystal, and you should ask the vendor supplying your machine what is the best to sterilize your machine. And some wipes, like this wipe, I've just hidden the commercial name here, can be used to wipe out all the wires, all the connections, and the machine itself. Okay, let's go to where the money is. What is the echocardiographic findings in COVID-19 pneumonia? We tried to answer this question in our institution, and we have published this retrospective cohort study, echocardiographic findings in COVID-19 pneumonia, and that was published very recently in the Canadian Journal of Cardiology. In this study, we aim to characterize the echocardiographic phenotype in patients with COVID pneumonia. We included 74 patients with average age of 59 plus or minus 13, Most of them were males. I don't know, women are always lucky, even in COVID-19. So those patients were admitted with COVID-19, and all of them were swab positive. So we excluded patients with negative swab, even if they have the typical features in the CT, just to be consistent. And we excluded also patients with previously abnormal echo documented in our own hospital. So just in order to be able to claim that these findings are related to COVID rather than anything else. We did a level 1 British Society of Echo Transthoracic exam. Level 1 means very basic, just for volumes and for major structural problems and to assess the pulmonary hypertension. We categorized the data in all patients, patients with normal RV systolic function, patients with impaired RV based on the fractional area change. There was no difference in terms of gender, ethnicity, and risk factors. And from the lab perspective, the white count was higher in patients with RV systolic dysfunction. Was higher in all, but it was higher in patients with RV systolic dysfunction. And that is not a surprise. Patients with more severe disease were more prone to have RV systolic dysfunction. D-dimer, and this is the point that Professor Shaheen highlighted, that's very important because we surprisingly found D-dimer is almost high in all patients, whether they have RV dysfunction or not. But of course, higher in patients with RV dysfunction. Almost all patients had high D-dimer, which really supports the theory of thromboembolic pathology in those kind of patients. RV dysfunction was not related to mechanical ventilation because some would argue that, okay, you have done echo in patients, most of them are mechanically ventilated, that's why you saw RV dilatation and dysfunction because of the mechanical ventilation. We know mechanical ventilation parameters like PEEP can impress the RV and cause some dysfunction, but that was not true in our study because some of our patients were not mechanically ventilated and still have RV dysfunction and RV dilatation, even if they are not mechanically ventilated, which again supports that this is a finding or a pathology that happens with COVID-19 pneumonia rather than mechanical ventilation. We were concerned at the beginning about the LV because a lot of papers came that STEMI with COVID, myocarditis with COVID, so we were really planning to assess the LV, and we were expecting that we will see a lot of LV problems. But out of the 74 patients, only 8 patients had LV impairment, some of them mild and moderate, and 2 only had severe LV impairment. On the other hand, 41% of the patients had RV systolic impairment. So the RV was the most commonly affected chamber in the heart, not the LV. And we assessed the RV function by 2 methods, the TAPC and the fractional area change. Surprisingly, the TAPC was more or less preserved in all patients. However, the fractional area change was obviously down. That's why we categorized patients according to fractional area change, whether they have dysfunction or not. So the radial function of the heart was impaired, of the RV was impaired, but the TAPC, the longitudinal function, was preserved. And we will see from this example, this is one of the patients that was not mechanically ventilated. That's why we could get a little bit good image. You can see here, this is the typical echocardiographic thumbnail or icon for in COVID. From what we have found, a small hyperdynamic LV, and the right side is dilated and not contracting. You can see here the mid-free wall is almost akinetic, and you can notice that the apex is preserved, and the basal lateral free wall is more or less still contracting, and the TAPC is more or less preserved as well. So the problem here is localized wall motion abnormality, the so-called McConnell sign. We know McConnell sign is not specific, but it is very common in patients with pulmonary embolism. So we can see that's why the radial function is affected because of this wall motion abnormality, but the TAPC is more or less preserved in many patients. TAPC gets bad at the end. So that's why it is more correlated with mortality, because we call it the last man to fall in the battle. So radial function is affected first, and then at the end TAPC comes down, and that identifies patients with very poor prognosis. It was not a surprise to find in the RV dysfunction group that high and intermediate probability of pulmonary hypertension was more prevalent in that group. And the fraction area change was correlated with the D-dimer, the CRP, and the high sensitivity troponin. There was correlation with all of these parameters. These are some kinds of some patterns that we have found. Again, the localized wall motion abnormality of the RV. Even if the image is bad, like in patients with mechanical ventilation, you can still see that the LV is small and hyperdynamic, is not affected, but the RV is quite big, although I don't see clearly the lateral wall, but this is the real life scenarios that you can get, very dilated compared to the LV and impaired interstitial function. Subcostal view in some patients, although very bad image, but I wanted to get this in order to show you even in very bad images, still you can get data. You can see here the RV is very impaired. Here, it is not contracting at all and dilated compared to the LV. And that's another example with RV focused view. When we say RV focused means we need to be at the LV apex and then tilting the probe to get the RV in view. So the conclusion of our study was that RV dilatation and dysfunction is common in patients with COVID-19 pneumonia and the elevated high sensitivity troponin. In contrast, the LV is seldom impaired and more often hyperdynamic. So to conclude my talk, COVID-19 does not equal echocardiography. Only perform echocardiography if it will have an immediate clinical impact. Perform a focused level 1 scan, very basic scan. Do not take a lot of time. Reduce the exposure time as much as you can. QE is aerosol generating procedure that equals full PPEs. Dedicate a scanner if possible for COVID patients if you can, and look carefully for the RV. Thank you so much. Allahumma mahfouz Masr.
Thank you, Dr. Hani, for this great talk. Dr. Hala, you can...
Thank you very much, Dr. Hani, for this very comprehensive talk about the echocardiography in COVID-19 patients. In fact, it's very important and very daily practice in cardiology department.
I was very impressed من المحاضرة بتاعت دكتور هاني والمفاجآت اللي اتقالت في المحاضرة دي ان هو the left ventricular dysfunction is not that common، بالعكس right ventricular dysfunction. فأنا كنت حابب أسأل do you think يا دكتور هاني this is the mechanism of this right ventricular dysfunction, is it due to myocarditis or not، ولا ده نتيجة الchest infection والنمونيا فبتعمل back pressure على ال right ventricle، or you think that this might be due to pulmonary embolism? And did you يعني expose your patients for CT to exclude pulmonary embolism in this particular study ولا لأ؟ We are talking about the mechanisms behind, I'm sorry that some Arabic language dropped from me, but we are talking about the mechanisms of the possible mechanism about in this right ventricular dysfunction. What do you think?
دكتور هاني معلش السؤال ده برضو، هل كان في الاستادي بتاعتك البلمونري هايبرتنشن والرايت فنتريكولار دايلاتيشن هل عملت كورليشن ليهم مع الدي دايمر والليفل بتاع الدي دايمر ولا لا؟
تمام. Thank you so much for these very clinically relevant questions. Yes, the answer is yes. The first part of Dr. Sameh Shaheen, yes, the mechanism of RV dysfunction in those patients is definitely multifactorial. One of them is hypoxia itself causes vasoconstriction and causes back pressure on the RV. And some of them, especially for the mechanically ventilated patients, the beep can cause that. But in our study, we have found in the non-ventilated cohort, they had similar, more or less similar prevalence or incidence of RV dysfunction and dilatation. Second thing is the D-dimer for Dr. Khaled Shokry. Yes, the D-dimer was higher in patients with RV dysfunction. And actually from the correlation we have shown, I have shown at the end, there is a correlation between fraction area change drop down and the D-dimer. So the higher the D-dimer, the lower the fraction area change. And that actually supports the theory of thromboembolic mechanism in those group of patients. D-dimer was almost high in almost all of them. Like 1 or 2 patients only at the beginning of their admission had little bit, like not that high. The lower D-dimer level I got in this study was 365, which is again high. So all of those patients have high D-dimer. That's why in our hospital, we started to run a randomized study for therapeutic, not prophylactic now, therapeutic anticoagulation for those patients. And actually there was a study recently published, but it was a retrospective study, so we cannot really infer the causality directly, but it showed better survival for patients that were put on therapeutic anticoagulation. For the question about CT, some of those patients, because these are all studies were done on clinical decision. It was not for research. So whoever was sent for echo, we collected his echo data. We didn't do this for research to start with in order to reduce the exposure. So some of those patients had a CT done on clinical basis, and yes, the incidence of PE documented in CT was higher in patients with RV dysfunction. But we still think, and that thought is supported by a study that was published recently in the New England Journal of Medicine. It's a pathological study showing the lung tissue and showed microembolization that shouldn't show up in the major arteries in the CT. So there is microemboli inside the microvessels. So even if the CT didn't show like major arterial blockage, there will still be microemboli within the small vessels. So that's why we are now in Birmingham are very, very like directed towards this disease is thromboembolic. The thromboembolic pathology in this disease is very high, and we need to start therapeutic anticoagulation for those patients. Yes.
Hani, also, have you tried the NOACs as an anticoagulant, or you depend on the low molecular weight only?
No, we use enoxaparin, low molecular weight heparin, because many of those patients are in the ICU setting.
Okay. دكتور هالة، نبتدي بقى أسئلة البارتيسيبانتس.
علشان الكارديولوجيست بتوعنا والايكوكارديوجرافرز اللي في مصر very very interested in echocardiography when we use it and how we use it in a very contaminated area. So number one, that echocardiography can be used if it will reach the patient management or if it is life-saving. It's not for everyone, because even the transthoracic echo carry the transmission of infection and elimination of infection for the echo machine itself, for the bed, for the lab, the echo lab, in addition to the personnel. So we have to be very conservative. This is number one. Number two, transthoracic is much better to use than transesophageal and any other techniques like the contrast echo, transesophageal echo.
Yeah, there is a question here asking about follow-up of patients with RV dilatation and Walbush abnormality, whether it is reversible or not. This is from Dr. Sharif Mansour. Thank you so much for this question. Actually, this is another study we are conducting at the moment, and we are started to request follow-up echoes after 3 months for all the discharged patients, because the mortality reached about 30% of our cohort. And we will repeat the echocardiography with detailed scans to see if that is reversible or not. So thank you for the question. That's a question we are going to answer soon, inshallah.
Another question, Dr. Hani? There is another question. I did echo for pregnant 1 week ago. She had massive pericardial effusion, and she admitted in the Bardash. Then a positive COVID-19 was diagnosed. Massive pericardial effusion is a complication of COVID-19.
Thank you so much. In our study, out of the 74 patients, I had only 3 patients with mild pericardial effusion, and one of them had associated LV impairment, the one with severe LV impairment, and that was proven to be myocarditis even by MRI. So it is there, but it is not that common. That doesn't mean that any patient you encounter with cardiac issue, you will say, no, this is not from COVID. No, we have seen it, but it's very minimal. Because as I said at the beginning, we were focused on the LV. So we are waiting for the LV abnormalities, and then we were surprised that it is the RV, not the LV. LV impairment happens, but very less frequent compared to the RV.
Another question? Dysfunction was reversible in cured patients? Did ventricular dysfunction was reversible in cured patients?
Yeah, this is what I've just said.
The RV function.
We will repeat the echo 3 months later. Within the same admission, no, there was no reversibility because this is too short to say reversibility. We requested echo after 3 months, but none of them has completed 3 months yet. So that 3 months for the first one will be maybe next week or so. We started in March till May or something like that. Is written in the paper. So after 3 months from the first echo for each one, another one will be repeated, and then we should be able to answer this question. Inshallah.
Okay. Dr. Hani, this is the question from me. Which is the best for the patient and for the echocardiographer? Is to do detailed echocardiographic examination for assessment of the LV and RV function, or just to do echo and to make relation of the echocardiographic finding next?
No, the recommendation from all societies is to go for a focused, targeted study to decrease the risk of exposure and to decrease the time of exposure between the personnel and the patient. That's even if the patient is known to be negative. It is advisable to decrease the time. So the request, ideally, in the ideal world, I should have a question of the study, not just echocardiography. Now, echocardiography to do what? To assess the function, to look for a murmur, or to do what? So if a murmur and the patient clinically like asymptomatic, this is a kind of an elective study that should be deferred and postponed. This is not today. This is not during this pandemic. If the patient has query LV function because of heart failure or something, so LV function and RV function, baseline images, and quick look on the valves, and that's it. So do not go for sophisticated things at the time being in order to decrease the time of exposure. It's a basic study, level 1.
Okay, last question. Impact for hydroxychloroquine on the RV function in patient with moderate or severe COVID infection.
We don't know. We don't know this question because this is a large debate, and we could see that there is a retraction of one of the papers today from the New England Journal of Medicine, who claimed that hydroxychloroquine can cause harmful effects on the heart. This paper was retracted today. Second thing, that we in Birmingham or in the UK, we do not use hydroxychloroquine as one of the drugs in the regimen. They just go supportive and ventilation. So I don't know the data to answer this question.
Okay, thank you so much, Dr. Hani. And now we are moved to the last. It's another important talk for Dr. Shaheen. He will talk about the Nebivolol in Professor Dr. Sameh Shaheen.
I think we have a lot of information that we've got from the just need a feedback. So this is a kind of reaction I've got from some of my patients because you know that the social media and everybody is talking about COVID-19 and the relation between COVID-19 and the hypertension and the drugs. So many patients are asking you, and it's very important to reply to your patient whether to use certain drugs or not. Among the drugs that has been asked about is definitely the beta blockers and the RAS blockers like the ACE or the ARBs. And you all know the debate about and the row about this. And you have heard again from Dr. Hani that a lot of patients with COVID-19 are suffering from hypertension. There is an increase in the incidence of hypertension with the increase with age. So actually we don't know whether hypertension is playing a role in the severity of the infection or it is just a correlation with the age. So this debate has not been solved yet. And on the other hand, also we know that the presence of cardiovascular disease is having a high risk for the future or the prognosis of the patients with COVID-19. Most of the recommendations until now for the debate about the RAS blockers is to continue on the same drugs because we have no evidence until now that the RAS blockers is doing any harm to the patients who are already on these drugs. What about beta blockers? I think that beta blockers again should continue to be used in this regard, especially in the era of this pandemic and the anxiety that it is causing to our patients. And this anxiety will definitely cause activation of the sympathetic system with all the complications of the sympathetic system over activity. And we have to remember that beta blockers is still one of the drugs that can be used in the hypertension patients. And this is the latest European Society of Cardiology guidelines on hypertension, and beta blocker is still one of the that can be chosen among others in hypertensive patients, especially if the patient is having on top of hypertension, for example, ischemic heart disease or a history of myocardial infarction or heart failure or tachycardia. A tachycardic patient again is an indication for the use of beta blockers. And just to remind you that there has been a more aggressive approach to the targets of hypertension nowadays. And in the European Society of Cardiology, we are now targeting a blood pressure, a systolic blood pressure below 130, but be cautious not to go below 120. This is again in red. We don't have the data of safety if the systolic blood pressure is below 120, but definitely the 130 is a little bit more aggressive than the previous guidelines, which was 140. And for the diastolic blood pressure, again, it has been recommended to be below 80, but not below 70. So the range has been put to be between 70 and 80. And we have to teach our patients how to measure the blood pressure. We are talking that it's not essential to get all your hypertensive patients to the clinic. You have to tell the patient the proper way to measure his blood pressure at home. This is very important in order to get a correct measurement of the blood pressure monitoring. And I think it is a class 1 recommendation by all of the guidelines, whether American or European, that home blood pressure monitoring throughout the course of the patient follow-up is very well recommended by these guidelines. But you have to remember, why was beta blocker not very welcome? The old beta blockers was not very welcome in the recent years as a treatment of hypertension. One of the causes of this step backward for the use of beta blockers is the CAFE trial. As you know, this is a sub-study from the ASCO trial, where atenolol proved to be as good as amlodipine in reducing the brachial blood pressure. When the blood pressure is measured from the arm, the peripheral pulse pressure was almost the same as compared between atenolol and amlodipine. But if you measure the central aortic blood pressure, you will find a difference, much lower. Actually, it was almost 3 millimeter mercury lower with the amlodipine compared to the atenolol. And that's why the clinical outcome was in favor of the amlodipine compared to the beta blocker. But remember, this was an old generation of the beta blockers. We always have to remember that Nebivolol is a new generation, and it's a vasodilator beta blocker through the increase in the nitric oxide through the endothelium. So it's a nitric oxide mediated vasodilator beta blocker. So it has the advantages of being a beta blocker, but still is having this potent vasodilator effect with all the clinical value of this. And again, it preserves the endothelial function, so it prevents or actually reverses the endothelial dysfunction through this antioxidant effect. So if you remember this study, it was a very important study that showed that through Nebivolol, we can improve the reaction to acetylcholine. You can see a vasodilatation effect in the Nebivolol patients compared to atenolol patients who actually proved to be as ineffective as placebo. So acetylcholine proved to be vasodilating if the patient is having Nebivolol. This is very important to remember, to differentiate between Nebivolol and atenolol, and whether this is having any clinical outcome or not. Yes, we know that when Nebivolol was compared to atenolol, you know that there was no significant difference in brachial pulse pressure, but there was a typical reduction in the aortic pulse pressure with the Nebivolol compared to the atenolol. Again, it is replicating the study of the CAFE study, which was comparing atenolol to amlodipine. So now we are having this again effect of Nebivolol on central aortic pressure, which is believed to be very important clinically in preventing a lot of complications. And the difference was almost again in the same range that we have observed in the CAFE study. So this is the major difference. Whether it is as strong as other types of beta blockers, as strong as an antihypertensive drug, yes, we can see here that Nebivolol fared as good as metoprolol, even better, and the p-value was significant in reaching a good control by most of the patients. So it's a good antihypertensive, a strong antihypertensive drug, not only the vasodilator effect, but it is a good antihypertensive drug. Again, comparing it to another beta blocker, which is the metoprolol, the same effect on central blood pressure, the same reduction in systolic blood pressure in the aorta compared to metoprolol. The reduction in the pulse pressure is very important again, and this will be translated into cardiac protection. It will be translated into reduction in the LV wall thickness and LV mass. And we know that reduction in LV mass improves the prognosis of the patient. On the other hand, you can also notice improvement in the insulin resistance as regards the carbohydrate metabolism, improvement in insulin resistance, while this was not happening with the other types of beta blockers like the metoprolol. Again, you can see reduction in the incidence of new onset diabetes. Again, one of the feared complications of hypertensive patients using beta blockers. You can be afraid of having new onset diabetes, but with Nebivolol, you can see that it is even better than placebo. there is no increase in the incidence of new onset diabetes. And for all the parameters of blood glucose, whether it's fasting or glycated hemoglobin, there is reduction in the blood sugar. So you don't have to be worried about the side effects of increasing the diabetes severity or the control of diabetes or even the lipid profile. Again, you can have this nice reduction in lipid profile, in renal protection, reduction in microalbuminuria, reducing the body weight, and of course, because of vasodilatation in the skeletal muscles, you will have studies that prove to have improvement in physical capability. So we have this new beta blocker with all these advantages compared to other beta blockers. And in the seniors trials, all of you remember that this was a heart failure patients in elderly patients, and you can see reduction in mortality similar to other beta blockers. It's a very effective drug mentioned in the guidelines to be used in heart failure patients, especially elderly patients, reduction in mortality and in sudden death. Again, this was proved in the seniors trial, and especially in patients having coronary artery disease, very effective reduction in ischemic events. One last point I would like you to take care of, that using beta blockers in the era of COVID-19, remember always that it might cause some cross-reaction with chloroquine or azithromycin. It's not a severe combination contraindication or a severe increase in the incidence of QT prolongation. No, it's only mild, but remember to take care patients receiving these drugs. If you are giving chloroquine or azithromycin or hydroxychloroquine, you can have some increase in the QT interval. So these are the drugs that you should be always cautious in this regard. Even also the tocilizumab, again, Ubardo in the amiodarone and the quinidine, you have to take care of the QT interval. So I have to leave you, my dear colleagues, with these conclusions. These are the messages that you have to remember. That beta blockers are still the cornerstone in the treatment of hypertension, ischemic heart disease, and heart failure, and that the third generation beta blockers are different from the second generation, with no side effects that you used to be worrying about. And that this is, of course, is due to the beta-3 agonistic reaction and the vasodilation action of the Nebivolol. It's very important. We have evidence from clinical trials that Nebivolol is effective as an strong cardiovascular mass. It is very much well tolerated with improvement in exercise performance and exercise tolerance, and it is at least neutral to patients with diabetes because, of course, of its beta blocker action on the beta-3 receptor in the pancreas. So it has a neutral effect on diabetic patients, and the metabolic syndrome and the lipid profile of the patients is not very much affected by this, by Nebivolol. Thank you very much for your attention, and back to you, Professor Hala.
Thank you very much, Dr. Sameh. This elegant we got very impressive information from your presenter.
If someone is confirmed with COVID-19 and began to pneumonia symptoms on him, can we still able to use beta blockers with this patient, even if it is Nebivolol? I think yes, if the patient is having pneumonia, there is no indication to stop the drug unless the patient is having severe bronchial asthma. But chest infection and pneumonia per se is not a cause to stop a beta blocker if the patient is already on a beta blocker, unless, as I mentioned, that the patient is having severe type of bronchial reaction. In this situation, again, as Dr. Hani mentioned, that sometimes the patient is ventilated, so he's not taking his oral medications. Sometimes we give him, if the patient is in real indication for parenteral beta blockers, we can give this patient like parenteral or in the nasopharyngeal tube if you can. But I don't find a reason to stop a beta blocker routinely in all patients with COVID-19. No, I don't find this. Okay. Dr. Hala, do you have any other question?
Yes. Start the anticoagulation early, as early as we can. And how about during the follow-up period and the patient is sent to home?
I think starting oral anticoagulants, and I will hear from Hani also, starting oral anticoagulants is not routine in all patients. Many of the centers are using the D-dimer to determine whether this patient is in need for having oral anticoagulation. So if the D-dimer is starting to rise above the normal with the certain figures, they have certain figures in this, then we can start oral or parenteral anticoagulation. And with the more severity of the increase in D-dimer, then you can go to the full doses, not only prophylactic, but the full doses of low molecular weight heparin or the full doses of NOACs if the D-dimer is very high. Regarding the follow-up, I think that we don't have data enough for following the patients in this regard. But I think that after resolving the pneumonia, after getting all the markers back to normal, after being negative from COVID-19 by the swab and the PCR, I think we can stop safely the oral anticoagulants or the parenteral anticoagulants if there is no other indications, after returning back to normal in all parameters, whether laboratory or clinical. What do you think, Hani, about keeping the anticoagulants in the follow-up? For how long should we keep the anticoagulants?
Yeah, as you said, Professor Shaheen, this is a totally new era, and we need a lot of studies to define the optimum duration. But what happens in my institution, at least, is parenteral anticoagulation for the admitted patients with an ICU, ventilated, or in the normal ward. All of them are getting whether prophylactic, but now we are started to move into therapeutic, and we are running a randomized trial to see the benefit of therapeutic versus prophylactic anticoagulation in those patients. Regarding the long-term anticoagulation with oral medications, those till the moment, because we do not have randomized trials for follow-up. Follow-up is very limited now everywhere. Those with confirmed CT confirmed pulmonary embolism plus echo findings pulmonary embolism, which are not all of our patients, like about 20-25% of them were diagnosed with PE documented by CT. Those patients will be dealt with as regular PE, so they will be kept on anticoagulation for a while. And because this is a reversible situation, so 3 to 6 months of anticoagulation might be reasonable, provided a follow-up echo. That's why this is one of the things we will be looking for, because patients with persistent RV dysfunction might be in need for longer-term anticoagulation, and there may be those who will develop chronic thromboembolic pulmonary hypertension, for example, and those patients will be kept for life on anticoagulation. So we don't have a solid data to answer this question, but at least those who are clinically proven to have pulmonary embolism will be dealt with as regular pulmonary embolism cases.
Yes, totally agree. I totally agree with you. That if there is an indication like atrial fibrillation or pulmonary embolism or something like this, then the same rules apply. But if the patient is having only just right ventricular dysfunction without proved pulmonary embolism, this is another story, and Dr. Hani will give us another talk about the follow-up of these patients. So, Dr. Hala, if there is no other questions, I think we have to.
I just have questions. One for the Nebivolol.
The last question.
If patient develop heart failure with the fine basal crabs.
Yes, we have to apply the same rules that if the patient is having already beta blockers and went into pulmonary edema and congestion, then you have to continue on beta blockers. Maybe you can decrease the dose a little bit. So don't stop beta blockers if the patient is already on. But if the patient is not having beta blockers before, then wait until the patient is completely dry and then start adding beta blockers with a small dose, with a very small dose, with a slow progression in increasing the dose. So the same rules applied with patients COVID-19, whether they are having beta blockers before or not.
Last question, this webinar, many of them asking about the cutoff value for D-dimer to diagnose COVID-19 infection. Is any cutoff value?
D-dimer is not for diagnosis. I mean, you can't diagnose COVID-19 or even a DVT or a pulmonary embolism with. It's a good negative test, as we always know. But we have seen from many reports that the higher the level of D-dimer, the worse is the prognosis of the patients. So it is related to prognosis rather than to diagnosis. And they are taking this as a guide to add the anticoagulation. Dr. Hani, if you want to add on this.
No, I absolutely agree. It is not one of the tools to diagnose COVID pneumonia. It is adjunctive tool to assess the need for anticoagulation and to know something about the prognosis, as you nicely mentioned. Yes.
So as a moderator of this webinars, I think we have to give a great thank to Professor Khaled Shokry being with us, and also to Professor Hala Mahfouz for moderating this excellent webinar. And special thanks to my dear colleague, Dr. Hani Mahmoud from the UK, who gave us from his time, valuable time to share with us his experience and this great paper that he published recently in the Canadian Heart Journal. Many thanks, Dr. Hani, and I'm sure that you will be with us in the next, in the coming webinars. We would like you to be one of the participants in this webinars. And thank you very much for all the participants and our dear colleagues. We have good, excellent number today from many parts outside Egypt again. And I think goodbye from now, and we'll see you tomorrow.
Before goodbye, Dr. Sameh, for the participants, I would like to thank all of them. Thank you so much. In fact, you enrich our webinar. But if you please, if you are able to go to the iHeart website and put your comments or opinion, so we can have the feedback from you. Thank you all.
Thank you.